because this case was my case. So the feeling is totally different when you meet your case with this problem. But finally, I will show in this presentation how to be careful when you diagnose ectasia, because many cases you may find the signs of ectasia, but actually they are not ectatic disorders. Let's start with the case 1. 38 years old female, past history of LASIK OU 2 years ago by me. On the last visit, which was 1 year ago before presentation, the unaided visual acuity was 6 OU, and the patient was so happy as shown in this reaction. But on this time, on the year of on this date, July 2019, this patient came to my clinic with panic and depression, with rapid drop of the visual acuity. The unaided was unbelievable. The unaided visual acuity was just 160 in the right eye and 360 in the left eye. The best corrected with the unlogic refraction was 260 and 660 in the other eye. This was a manifest refraction -8, sphere -9 cylinder, and in the other eye -4 and with -5 cylinder. Normal intraocular pressure, and the fondi very minimal key piece, which was very, very minimal, down to be insignificant, with almost clear corneas. I was asking at this time who switched off the room light. It was a horrible moment. I could take this photo by a street lamp through my mobile for the cornea at that time. If you look at this cornea, you will find no abnormality could be detected on this photo, especially after the refractive laser-based refractive surgery. You may find some infiltrates, very fine infiltrates may be present in the bed. So it may be insignificant in this case, but in other cases could be of significance. I sent this patient immediately for corneal imaging to get this pentacam. I found that there is a very significant inferior steepening in the center part of the cornea, and found this picture, which will give you impression of ectasia at the first moment. Actually, the assistant doctor who made this investigation came to my clinic, to the side clinic, while she is very sad and saying, while she is crying, "Sorry, doctor, she is ectasia." And I had on that day one of my professors present in my center who said the same. It's ectatic disorder, and it's post-LASIK ectasia you have to deal with. I was shocked on that time, but when I went back and sat on my seat and thought for a moment how to be with this steepening in the center cornea with this thick cornea. The pachymetry, when I went down to the pachymetry, I found that the ectatic part of the cornea and the topography is the thicker part, so it should be other thing than the post-LASIK ectasia. I have to think again about that. I found that the thinnest allocation is 539 and up to 669 in part of the center of this cornea, with a very normal back elevation, with a very normal the same pattern of the pachymetry map coincides with the normal part of the posterior elevation. So it's not ectatic disorder, and I will think again about this case and follow her up. But the key here that this patient with past history of cornea refractive surgery. So the first thought to rise in your mind with this picture that it should be an ectatic cornea. But you have to think slowly. You have to think. You have don't be hurried to diagnose, but you think, and you have to review every single point in your imaging very thoroughly and carefully. And this is the other eye, the same pattern, but somewhat later than the first one. And I got this specular microscopy and the anterior segment OCT for this patient to find this. The subjective refraction is very far from the manifest refraction, and the cornea is thick at the ectatic part, and also the corneal endothelium as well. I was thinking in the corneal edema. So I like to check for the endothelial status for any reason to decrease its function with corneal edema. So the best corrected was 636 with this manifest refraction. The treatment in that time I thought to deal with as a case of unknown corneal edema until I can find the cause. So I started this time with the normal saline, sodium chloride 5%, the prednisolone, and copious lubricants. But unfortunately, after 5 days from this treatment, the patient called me that she's worsening, not improving. So I asked her to come to the clinic and found this presentation, found these changes in the cornea. The center corneal opacity shown in these pictures, as you see, it is not related to the total cornea, but just the central part. So this case with the central corneal edema due to an inflammation, either to be autoimmune or to be interstitial keratitis after herpes, herpetic uveitis or herpetic keratitis. So now the mind is changing, viral or autoimmune. I start first with carefully to be away from the deterioration of the virus if it's present. So I choose on that time to start with the oral acyclovir and topical ganciclovir, fluorometholone, very little dose of the fluorometholone and immunomodulators. And after 13 days, I found no response. So turn to the other option, which is an autoimmune disease. So turn to aggressive autoimmune therapy together with a consultant of autoimmune disease to start a systemic therapy with injectable methotrexate oral prednisone, 100 milligram per day in Solipred, the topical hydrocortisone and primidine to control the intraocular pressure. And after 2 weeks, we found a marvelous improvement. So this picture is for Pentacam for this patient after around 1 month from starting therapy with much less corneal thickness and much less Kmax. As I show now, in the first one, the thinnest location was 540, and now it's 510. And finally, you will find that the Kmax, it was 56, now it's 54, starting to be less in both eyes, the same eye, the other eye the same. The Kmax was 51.3, now it's 45. The Kmax decreased around, is reduced around by 6 diopters, and the thinnest location was 540, now it's 520. 3 weeks more, there's a marvelous improvement in the features shown in the Pentacam. And finally, this is the picture of her cornea again, like the first presentation, with unaided 612 and 609, almost clear cornea. And she restored her vision and mood wellness, and me too. This is the first case, which was a horrible case. and I have learned a lot from this case, to think about other things and to take care and pay attention to every single insignificant point which can I find in the patient. I didn't care about the very minimal key piece on presentation, but actually, if I pay this attention for it at the first time, I would manage her in different way from the start. Let's go for the second case if I have time. This patient came to my clinic seeking for refractive surgery. She's a 26 years old female with a very, very low visual acuity, and she refuses to wear the glasses to correct her vision. This is the pentacam. I will show the clinical data and went back to the pentacam. The clinical data for this patient, the right refraction was -1 sphere, -8 cylinder. The left eye, almost the same. The unaided less than 360, and the best corrected is 624, and left eye is 618. The IOP is normal, clear lenses, and normal fundi. Let's go back to this pentacam. When you look at this pentacam, you will find that this is a very steep cornea. The key one is 47, the key 2 is 54, which is totally out of normal. So this pentacam is showing that this patient is conic, but look at the pentacam, the steepening is present superiorly and inferiorly at the same time. Also, it's almost equal, superiorly and inferiorly. It's not the pattern of the keratoconus. Even the central nipple cone, it will be shown in different category and different features. So look at the back. The back is still normal. And I'm believing there's no keratoconus without back changes at all. I didn't find any way in my life that there is no keratoconus without posterior changes. The keratoconus, the posterior disease before being anterior disease. And it's proved now by epithelial mapping, which help diagnosis of the very early changes in the epithelial thickness with complete anterior surface and changes in the back, which will be shown in the changes of the epithelial behavior. So many surgeons before coming to me refused to do some refractive surgery for her, and they couldn't diagnose her as a keratoconus. The issue is here in this picture. You will find that there is a circular, extensive corneal degeneration, which make this cornea looks like the cornea ablated for a hyperopic correction. You will find a very deep center, a very steep center with very flat mid-peripheral cornea. So the corneal degeneration did these changes, like a thinning in the mid-periphery causing a counteracting steepening of the center cornea. So this cornea is not keratoconic at all. This is the other eye. And so, what's the diagnosis in your opinion? Is it keratoconus? I said no. Then what to do? My diagnosis is pterian margin degeneration versus advancing peripheral corneal degeneration. The pterian margin degeneration with actual thinning, not just degeneration, which will be marked thinning in the cornea, so it's not pterian margin degeneration. So my final diagnosis is that it's advancing, strange, rare cases of advancing peripheral corneal degeneration, like shown in this image. Thin body with a normal head. This thin body will show that head is larger than normal, but it's still normal, with a normal circumference and measurements. In your opinion, how to manage this case? Would you do a refractive surgery for her? Would you do customized ablation procedure like topo-guided or wavefront-guided ablation or others? Upon myself, I have done a customized ablation for her with a very good outcome. This patient could see much better than the glasses, around 618 unaided, and she's stable until now after 3 years of follow-up. So don't let the papers to deceive you. You have to pay attention to the clinical presentation and every single point in your data before going to the diagnosis. And thank you so much.